you. Thank you again for the invitation. The topic I've been asked to speak about is how to manage rectal prolapse by laparoscopic surgery. So to that end, I'm not going to speak about perineal approach, Altemeyer or Delorme. I'm just going to concentrate on people that will be candidates for abdominal approach. I will speak about particularly three issues. One is the recurrence rate, which is the never-ending discussion. Two is whether resection is appropriate, when, why, how, and then the rectopexy. So the published recurrence rates are an issue. As this meta-analysis shows, the published rates, they do not match with the estimated rates. Let me explain. Estimated means that you're using time. So you're using actuarial analysis where you calculate the time, whereas it seems to be, with the exception of the first paper from 2001 in Techniques, where the recurrences were correct, that most of the papers, they're doing a fraction. So if they have 10 cases recurring out of 100, they publish a 10% recurrence rate. The point is that recurrence rate is not a fraction. It's an estimation of time. So you need to take into account, when you read the paper, make sure that they use actuarial analysis, otherwise you have a misinterpretation by 47%. Another very important editorial point, I don't think we should publish any papers on recurrence rate unless there is sufficient time. If you see here, this is a large series of 643 patients in disease of the colon rectum, where if you just wait 10 years, you get up to 30% almost. So it's just a matter of time. Resection. It has been said a long time ago that resection does not decrease recurrence rate. So there has to be a different reason to offer a resection. In fact, if you look again at retrospective data, a large number of patients, and resection doesn't really change much in recurrence rates. It has been said, though, from some Scandinavian studies, Lukkonen, particularly, that if you add resection, they may end up being constipated, and many of us have observed this. However, the issue is not, I believe, this is my opinion, I don't think it is about the redundant colon, which is a very mechanical, observation. I think it's more about functional studies they should be doing before starting or offering surgery, like a clustering of the rings of a colon transit time, for example, in the sigmoid colon. And also validated the constipation scores. If you resect, you may have a leak, of course. But I suggested a long time ago to spare the superior rectal artery laparoscopically and just take the sigmoid branches if you have to do a resection. So going to rectopexy, I think obviously you need to wonder, do I need a rectopexy or do I not need a rectopexy? This is also a very old concept, but just want to refresh everybody's memory. Again, look at retrospective data. You compare mobilization only, as pointed by the yellow arrow. You just do mobilization in a retrospective fashion, you don't see any difference. The mobilization only is actually coming from a very old school of rectal prolapse from India, a chap called Khanna, publishing a huge amount of patients, mostly male patients, which we don't see in the United States. And this is a great example where retrospective study can be wrong. So based on this, there is no difference. A randomized control trial in disease of the colon rectum in 2011 proven that rectopexy matters. So if you do pexy in a randomized prospective study, you show that rectopexy decreases actually recurrence rates. We have data up to 5 years. So let's go to more of a polemic topic. Dr. Corman reminds me that the adjective posterior of ventral is referring to where the rectum is actually suspended, meaning it's suspended to the sacrum or it's suspended anteriorly to the pubis. So accordingly, posterior rectopexy is an old art. This is all stuff taken by Dr. Corman's book. They were basically pexing even to the psoas muscle in the old days, but mostly to the sacrum. In ventral rectopexy, there are papers from the Royal College in England in 1949, pexing to the vagina. There were papers from Switzerland in 1960, pexing to the pubis. And this is a picture from Dr. Corman's book from a chap called Nigro in 1970, putting a mesh and fixing it to the pubis. So nothing new. A great study from Denmark, a randomized study, has been focusing on function rather than recurrence, because the claim to fame of ventral rectopexy is that the function, or so-called constipation, the function is much better after ventral rectopexy. Well, these Danish studies show them wrong and proven that ventral rectopexy did not make any difference. You can say this is a small study, 75 patients, but what you expect from a small country, it was a big effort. Now, you don't want government intervention telling you what to do because the meshes are eroding the vagina and prompting that kind of reaction. So if you accept that you have to do a rectopexy, whatever rectopexy you want to do, the next question is suture enough, or you need to have a mesh? This is also an old story. Going back to retrospective study, and you compare the two techniques, you don't see any difference. Where do you pexy? Some laparoscopic surgeons in the early 90s, they were proposing to pexy to the anterior surface of the sacrum. I personally don't. I personally place my sutures exactly on that spot. I stay medial to the ureter, and I stay lateral to the hypogastric nerves. Dr. Williams from England poses these questions in 2011. This is the colorectal editorial. It was asking, how far is the rectum really mobilized? Are you going all the way down to the levator and eye? How did you fix the rectum? Did you staple it with the hernia staples, one of those disposable devices, or tacks, or did you suture it? That the resection again impact recurrence? Open vessel laparoscopic. So we took some large data, about 819 patients, and we look at the mobilization, circumferential, posterior, or anterior only, and clearly circumferential mobilization decreases recurrence rates. You can see from 20 to 8.5 to 1.3. With a good follow-up. The so-called side ligaments, as you know from autopsy studies, they don't contain very often arteries in a minority of patients. In most of the patients, they contain nerves, and that's actually the reason why some patients may have functional difficulties. So the question was posed the same, and the study was divided in two groups, and probably because of disparity in numbers, you can see it's only 185 divided. We could not see any difference. I mean, statistically. I don't, however, particularly recommend dividing them. Are you going all the way down to the levator? Are you not? You see, I can't answer that question reliably because I have too few patients not going down to the levate, only 39 cases. And as far as mesh to suture, no difference. In a large amount of patients, comparable numbers and good follow-up. Resection, again, does not change anything in terms of recurrence, and it's done for other purposes. We don't need open surgery, as we know. So my conclusions are that I think you need to be careful at believing published recurrence rates, that you can do a resection if you feel you have to, but you don't need to take the inferior mesenteric artery. The rectopexy, I don't see any data convincing me that adding a mesh it's beneficial to the patient. Actually, I'm concerned about cost and infection rates, particularly if it gets near the vagina. And then mesh ventral rectopexy does not improve functional outcomes according to a Danish randomized control trial. Thank you.